hanging in there. We are headed to brunch soon, right after this. But before that, I am very pleased to introduce our next two speakers who I've met, I will say, on the conference trail many times. And so we are and have had great conversations about the work that they're achieving at their health center. And so we are really excited to bring them here to talk to you all about what they're able to achieve using data to drive increases in immunization rates, something we can all learn from and continue to improve. So without further ado, let me introduce Kalyan Gogineni, whose work as a Senior Quality Analyst in the Clinical Quality Team at Rodgers Health Center started in March of 2017. He brings over 15 years of experience in the healthcare field, working in various capacities in both administration and clinical departments. Working on the quality team, he analyzes data to provide better healthcare to the community by prevention and care. He brings a wealth of knowledge from the public health arena in removing barriers to achieve health equity and make healthcare more accessible for all populations. He is going to be joined by Aruna Konreddy, a computer science engineer by education, but after working as an application development specialist for Children's Hospital in Boston, her focus shifted to healthcare. She earned a graduate degree in Health Services Administration from the University of Kansas Medical Center. She currently serves as a Senior Quality Improvement Analyst at Samuel U. Rodgers Health Center, where one of her many responsibilities is analyzing data to improve clinical outcomes and quality of care. Please join me in welcoming our next two speakers.
Thank you, Nicole. Thank you, Nicole, and good morning to everybody. So in our health center, we implemented an immunization improvement project a few years ago, and we wanted to share the experiences and the success story so it might be replicated and be useful to other populations too. Just to give a background of our project, we are from Samuel U. Rodgers Health Center. We are from Kansas City, and it's a federally qualified health center. And in this slide, you can see the founder, Dr. Samuel Rodgers. He was the founding person in the community health center, and he was committed to bring healthcare to the community regardless of culture and background, and provide universal healthcare for all patients. And everybody is family at Samuel Rodgers, so we treat patients from newborns to elders. And we serve about 25,000 patients annually, about 80,000 visits, and 42% of our patient population is children under 17 years, and 31% of these patients are best served in a different language. And 38 languages were spoken. This is an older slide, so last year we spoke languages, we served patients who spoke 50 languages, so it's almost like a mini UN. And you can see the racial breakup of our patient population. It's very diverse in every aspect you can imagine. And 92% of our patients live below the 200% federal poverty level, and they qualify for some kind of a discount at our health center. And 40% of our patients lack insurance, so that's a huge barrier in itself. So since we are a federally qualified health center, we are supposed to be reporting out our measures, and one of those measures is immunization in the infants. We are reporting this measure out to UDS annually every year. So based on our performance, our quality is measured by UDS, and that's how we receive funds from the federal agencies. And in 2016, there was a change in the UDS measure from 3-year-old to 2-year-old. And it was a series of 24 vaccines that had to be completed by age 2. And in the HPV, also there was a change because it was a 3-dose schedule earlier, which got changed to the 2-dose schedule. So there was a couple of changes in both these UDS measures. And what the UDS childhood measure does is it reveals compliance versus non-compliance. So if the kid reaches year 2 and he is still not compliant, it doesn't track us anymore, but it is on us to make sure that the kid gets immunized. And the second thing that track is up to only kids who are up to 2 years, like what I was mentioning. And what it does not do is account for granular CDC dosing schedule, and also it doesn't evaluate children who are over 2 who are under-immunized. And in this slide, you can see a snapshot of where we were. In 2015, before the changes to the measure, we were at 73% compliance for 3-year-olds. And for HPV, unfortunately, we were at a very low percent. It was 15% completion rate for the HPV vaccine series. And in 2016, the measures changed, and you can see the huge drop. We fell down to 31%. And in 2017, we started to implement our immunization project, improvement project, and then we started to see the numbers go up. And just before pre-pandemic, our numbers were close to 50% completion for the 2-year-old immunization. And HPV was well over 70%. And we identified a few challenges over the course of the project, and we implemented interventions to overcome those challenges. Some of them were refusal due to financial reasons. So patients who were underinsured, they had to make sure that they were able to be covered for the vaccine cost itself, because HPV was $260, if around $260 or $270 if they didn't have insurance coverage. And then most of our patients frequently change their address, and we lose track of these patients because the mailer sent to them or a reminder card which sent to them never reached the patient. And there was also an interface issue back then because the state's immunization registry was not interfacing in a two-way with our electronic health records. And then there were cultural and language barriers. And then some of the patients were only coming during the sick visit. So we were never getting an opportunity to address vaccinations, because if Johnny is sick with fever, their mom is not interested in talking about the vaccines on that visit. So the interventions we came out with, the interventions we came out with was having education posters within the exam rooms and in the waiting areas. So some of these carried a very resonant message, like the one you see on the slide, where it would say, if there was a vaccine against cancer, wouldn't you get it for your kids? So it kind of conveys a very strong message. And clinical providers and staff, they were educated on approaching the patients who were having any vaccine hesitancy, and educating on and encouraging the patients to get their vaccines. Also, clinical staff, like in the session which Dr. Haller said yesterday, they were asked to encouraged to approach the patients with bundling. So these are the vaccines we recommend giving today, and just give them. Not saying, okay, we are giving Tdap and MCV because it's required, and we recommend HPV. That verbiage was discouraged, and we were just saying, these are the vaccines we would like to give today. And in childhood immunizations, the challenges was 18-month cutoff for all immunizations. And when we dived deeper, we found that Rota had a hard cutoff at 8 months. So if they missed the vaccine by 8 months, they were non-compliant for the measure. And the other one was flu. And there was a lot of refusal due to religious reasons because it had a pork derivative and other cultural barriers. With challenges, we also saw HPV vaccine had to be done by age 13, the 2-dose series for the UDS measure. And also parent considered it a settled permission to start engaging in sexual activity. So they were not willing to get the vaccine for their kids. And so HPV percentages, completion rates were significantly lower in the low teens compared to MCV and Tdap, where we were at 60% completion rate. And the interventions we did were using patient registries, reports, and pre-visit planning alerts. We mapped all our patients to make sure we were able to identify these care gaps whenever they walk through the clinic. And we also had patient education. We had care coordinator, outreach, who was addressing these care gaps and reaching out to patients to actively schedule them on the patients. And we were also able to remove some barriers by doing some outreach events. So we partnered with local schools and sports teams to bring about an increased immunization awareness in the community. So we brought in a couple of players. One of them was a Chiefs retired player. So Chiefs is a big deal in Kansas City. So yeah, so they came out. They had one evening. They had like a small sporting event where they coached and gave out some memorabilia, and it was a huge success. I think there were over 300 kids or 250 kids who came in. And then we also brought in one of the players from Sporting KC, which is a soccer team. So it had a huge response, and when they convey the message, it reaches out to, in fact, in addition to our teams. And we also have the VFC program. And for patients who didn't have coverage, we were able to coordinate with the pharmaceutical companies and get the patient assistance program for our health center. So our patients, whoever is needing it, they have to just submit in a couple of papers, and then they get the approval right away within half an hour before the patient visit is even done. So, and then in the technology we were using, as I was mentioning, pre-visit planning alerts, and then we interfaced with the Missouri Show Me Vax registry. Now it's a two-way interface. So whatever vaccines we give goes to the registry, as well as we are able to bring in any vaccines that the kids or adults got outside the health center as well. And my colleague Aruna will continue on how we used data and different reports to improve our project.
Thank you, Kalyan. So the vaccination is a team effort. We talked about it yesterday. It needs help of the front desk, point of care teams, CHWs, and recently we started collaborating with the WIC to improve our vaccination numbers. So we had one PI project before pandemic, and last month we started with another PI project because our numbers went down due to pandemic. So we are working on again improving our numbers. So we have workflows for the teams involved in improving immunizations. So the point of care team is the intake staff. So the point of care team does pre-visit planning and goes over the alerts that need to be addressed, the clinical alerts. And a patient's visit to health center is an opportunity to vaccinate. Every visit can be used for vaccination. So if the patient refuses vaccine, we document it, and later on we use it for reporting purposes to reach to that patient population. So outreach team, the quality team, gives them a list of patients that are missing doses so that they can reach out to those patients and schedule them. And we just started collaborating with the WIC team. We have in-house WIC. So we provide the WIC staff a list of health center patients that are overdue for immunizations. So when the patients visit WIC, their immunization appointments are made with the clinic. The quality team, between both of us, anything that is related to immunization data, quality team provides it. The immunization data is tracked regularly. So we have no-show reports for well-child checks and missed nurse appointments, immunization measures, vaccines administered, missed opportunities. All this data is shared with practice managers, point of care teams, and immunization nurse manager. We do our best to provide data in the most user-friendly way. And as FQHC, we have very limited resources, so we do our best. So we use care message for patients that are missing a vaccine. And for this particular slide, we have a message going out for 3 years and younger. So we have 1,449 patients in the cohort. And out of that, we have the message reached to 1,403 patients. And since last 2 months, we have sent 2,787 messages, and 1,302 patients were actively engaged. 52% appointments were made, 26% kept the appointment, and 22% care gaps closed. This could be immunization care gaps or other care gaps as well. So the childhood immunization status. So you see here 2 slides. One is before pandemic and one is after pandemic. So before pandemic, like Kalyan mentioned, we were at 49% for 2-year-old immunization. And after pandemic, currently we are at 30%. So that's why we started a PA project last month. And with a group effort, with a team effort, we are sure we are going to increase our numbers. So we already have 1% increase. So the immunization registry, we give patients that are missing HPVs on a monthly basis to our CHWs, and they call the patients and schedule appointments. And this is a PVP report, patient planning report, or pre-visit planning report. So the point of care team prints out these reports on the day before the patient visits the center. And they go over the care gaps that need to be addressed when the patient is seeing the provider. So these are the alerts that come up in the PVP report. So this particular patient is coming for a 15-month well child check. So they are overdue for lead, and they need 4 vaccines when they're visiting the clinic today. So it's a COVID-19 vaccine that they should get, a DTaP. So they got the first dose and they're due for second dose now, a flu vaccine, which they haven't gotten recently, and a PCV. They are supposed to get the 4th dose. And there are other alerts as well for dental visit and fluoride varnish that they should be getting. And this one is the missed vaccine report. So this is for well child checks. So this report shows the vaccines that got missed when the patient was visiting the clinic. So we have 5 vaccines that we track: Rota, DTaP, flu, PCV, and HPV. And we have 3 locations in Kansas City. So Cabot, Downtown Medical, and North Oak. So the denominator shows, for example, for rotavirus, if we take that, denominator shows how many patients have visited the clinic. This is for last month data. Out of those patients, the numerator shows how many patients got the vaccine. And the gap shows how many patients we missed. And especially Rota is a concern because they have a specific time period where they should be getting the rotavirus. And similarly with other vaccines, we have DTaP, flu, PCV, and HPV. It shows how the clinics are performing. So we go over, between myself and the immunization nurse manager, we go over the patients that were missed, find out why they missed it, and reach out to the clinic staffs to figure out and what can be done. And if possible, get the patient's schedule again for nurse visits. This is a no-show report that goes out to the practice managers. It's an auto-generated report. It's for well child checks. It gets emailed to the practice managers, who give this list of patients that had a no-show for the previous week. The front desk staff reaches out to this patient and reschedules the appointment. A similar report is sent to the practice managers of the patients that missed their nurse vaccine appointments. So this report gets auto-generated every week. The vaccine percentages. We track how compliant our 2-year-olds are against the 10 vaccines they get. The lowest is flu at 45%, PCV is at 65.8%, and Rota is at 70%. It gives the health center an idea of what the vaccination rates are for different vaccines. These are the vaccines that we track on a monthly basis. So I give this report to our immunization nurse manager for her to know what vaccines are being given on a monthly basis, and we track them. So for example, we have flu numbers that are increasing since January, which is a plus thing for us. And then if you go to pediatrics, again, we are in an upward trend. So I guess once we are tracking and how many doses we are giving, I'm sure our numbers will keep increasing. So the immunization management report, it shows the immunization status of the patient with respect to each vaccine. It gives users data based on the CDC dosage schedule for each patient. And this is the immunization management report. These are test patients. There are 1,653 patients, and you can see the columns, the fifth or sixth column, and it shows the immunization status of each vaccine along with the dosage detail. Example, for the fifth patient, this patient is a newborn, so they got a Hep A, but they are supposed to, is it Hep A? I can't see clearly. So they got their first dosage. So they are supposed to get their second vaccine, and then it gives the status for the next vaccines that need to be given to this patient. And this is how we reach out to the patients. So out of these 1,653 patients that we have, 2 years and younger, the high priority for our CHWs or the intake staff or the clinic staff to reach out to are those patients that don't have appointments on their schedules. So that's our highest priority. The medium priority is these are patients that are coming to the health center, but we want to make sure that they are reminded that they need to get their immunization as well. Those are in the orange color and they have an appointment. And the due soon is, we don't know if they have an appointment or not, but that time permitting, we need to reach out these patients as well. And the no action required is these patients are up to date with their immunizations. And the key takeaways is standardizing the workflows. So something that we have noticed is the clinicians, they have their own, the catch-up schedule. Some clinicians, they don't want to give all vaccines at one time. They split up the vaccines. And some clinicians, they don't want to give vaccines during the nurse visit because they're afraid they